All right, good morning and welcome to Bloom. We are so excited to see so many of you here today, joining us both in the room. And then we have, as I said earlier, we've got almost 30 joining us online today. Perfect. And then Katie is our moderator. Thank you so much, Katie, for joining us. My name is Kaya Verich, and I am employed by Fairview. I'm a nurse that works in the Cancer Survivorship Clinic at M Health Fairview, and just really excited to welcome you all here today. We also want to give a great shout out to Lissa and her team from the Masonic Cancer Center. They're the ones that are hosting us in this space with the food, organizing and coordinating. So a great thank you to all the efforts from Masonic Cancer Center. And we're just really excited to be here with all of you. That's the most important part of today, is those of you that are joining us. And if you can tell, we centered the day around the theme of bloom, really with that intention that, much like a garden, flowers are not as strong, or don't grow as strong, without proper tools such as water, fertilizer, sunshine, etc. And today, that's what we hope to provide for you, are some additional tools that you can use for yourself to help really bloom into your survivorship. This is a space for healing and learning and connection, and a reminder that whatever obstacles we face, we can all bloom where we're planted. So today we have a great lineup of speakers. We're going to hear about nutrition, about sexual health, and then we've got our panel of experts this morning, and then we'll move into a movement session followed by breakouts then. And in the breakouts, you can learn about mental health and self-care, navigating relationships. And then the other option is for a video or a film on tattoo and mastectomy scars. So the video will be played, and then we've got two participants who were in the film there for Q&A, as well as a local tattoo artist. So a really kind of cool, innovative session if you're interested in that. A couple of housekeeping notes. The agenda is going to be in your folders, as well as your parking pass, so don't lose that. All of these sessions are going to be recorded. So specifically for those breakouts, choose the one that feels appropriate for you today, but you'll also be able to access them online if you're not able to join. We also really invite questions and dialogue and discussion during the day, so feel free. We do have a microphone. I'll be your MC, if that's the right term. But for our online audience, please, we're going to ask that, just give a hand raise. I'll find you with a microphone. Also, we want to make sure for the online audience, put your questions in the chat. Katie will be asking them as well. Restrooms are going to be out the main hall, or you can sneak out that door if we don't bug Joel, our audio visual support. Straight down that hallway are where the restrooms, and then there's a water bottle filling station. And then the exhibitors, will have time during breaks for the exhibitors and after lunch, but please take your time to visit there. And then we also lastly have a fun backdrop in the atrium. If you want to take a picture of yourself today, go ahead and do that. So with that, I'm going to start our day. We are going to welcome our moderator, Dr. Chantal Muse. She is a behavioral health fellow at the Broadway Family Medicine Clinic. She received her PhD in counseling psychology from Northeastern University in Boston, where she also received her master's in public health. Her work centers on connection between physical health and mental health, and her research focuses on patient-provider communication, health disparities, and health equities. Welcome, Dr. Muse. Thank you so much.
Okay, hello everyone. Again, I'm Dr. Muse, and I'm so happy to be here with everyone. If you all could briefly introduce yourself to the audience.
Hi, my name is Ann Church. I am a breast cancer radiologist. Should I go further, or should I
Go further. What do you do?
Oh, well, I'm an associate professor at the University of Minnesota. I wear many hats. My main hat is a clinician. And so as a radiologist, I use tools, imaging tools, such as mammography, ultrasound MR, contrast mammogram, CT, such, to help detect and diagnose breast cancer. And in terms of the diagnosis, I'm the one who's doing the core needle biopsies. As part of the university and academia, I also am there to educate our future physicians to make sure that the physicians that leave our program are able to treat every woman equally, whether she enters a clinic in a rural setting or an academic setting. She has good access to care. And then as research, I am a part of the I-SPY trial. As some of you may are familiar with that. That is a drug trial that helps to decrease toxic harm from the main drugs that we've been using in the past, and how to innovate and figure out what new drugs with less side effects can help the patient. And as a radiologist, I read and interpret the response to neoadjuvant chemotherapy using the imaging tools. As educator, I'm the breast fellowship program director. So what else? I do, in terms of service, I try to help educate other physicians how to teach or how to use radiology effectively. So online, I've been teaching physicians in Mongolia and Ethiopia to help them improve cancer survival in their country. And then my heart is in the mentorship program in terms of making sure that all women and all genders have good access to good people that care about them.
Thank you very much.
Actually,
Oh,
have my
perfect.
own. So, hi, I'm Carol Lange, and welcome to the virtual audience. I'm a PhD researcher here in the Cancer Center. My lab is upstairs. I'm professor of medicine and pharmacology here. I think I'm in my 27th year as a researcher here. My lab is focused on women's hormones and women's cancers. So I have a breast cancer program, both ER positive and triple negative types of breast cancer we study in my lab, as well as more recently, we've been studying high-grade serous ovarian cancer and the BRCA genes and how they contribute to that. I also have a few hats. I'm Associate Director for Basic Science and Shared Resources here in the Cancer Center, where I help all the other faculty improve their science, improve access to emerging technologies in our 11 core facilities, things like proteomics, genomics, those kind of things. I am the director of a longstanding training grant, which is in its 50th year, NIH-funded grant, and it has 10 slots on it to train PhDs and postdocs, and I've been managing that for about 15 years. And that's been, again, a passion of mine, is to mentor our next generation of scientists. And many of those are getting both an MD and a PhD. And so we also have that program that I'm involved in a great deal with those people. I think the richness of my job is not only one-on-one teaching in the lab, where I'm teaching my 10 people, meeting with them very casually, walking through the lab, seeing how they're doing. They each have their own project, independent projects, and that are all kind of interrelated. And then in the broader community, kind of mentoring the emerging scientists, the postdocs, and the junior faculty, and helping them with their career development. And I love doing both. What else can I say? I think that's about it. Oh, nationally, I also love mentoring. I've been a long-term member of the Endocrine Society, which is a 20,000 member global society focused on the science and training and clinical aspects of all aspects of endocrinology, which simply means hormone action, all hormones in your body. And I'm the president-elect of that society, and I'll become president in July of that society, facing the headwinds of today's administration. So anyway, thank you.
Thank you so much. So I believe this is supposed to be an open discussion and dialogue with everyone here. So does anyone have any questions for our beautiful experts?
Hi.
And you can raise your hand or stand up.
I guess I would just say, like, what are things you're excited about? What are things that are coming out that you're just really hopeful for and want to share with us?
Yeah, so I'll tell you I mean, I know my lab and other labs, but so one thing I'm super excited about that we've sort of stumbled upon in my laboratory and what's sort of in the broader field is, so labs used to study, say, estrogen receptor only. So there were many labs just focused on the estrogen receptor, and then a bunch of labs only focused on another hormone, progesterone receptor, fewer. Some labs only the androgen or testosterone receptor. These are the proteins in your body that bind the hormone. So you have a small molecule secreted from the ovary, estrogen, and there's got a much larger molecule is going to bind it in the tumor cells. And so labs used to kind of just be in their lane. And now we realize that these hormones cooperate. They cooperate. Sometimes they antagonize each other. Sometimes they cooperate. It depends very much in the context of what's in that particular tumor. And you've probably heard that every single breast cancer is kind of different, even though we have the ER positives, the triple negatives, the triple positives. We now see that even in prostate cancer, there are some themes that we should learn in breast cancer. So now all of my breast cancer meetings are both prostate and breast, because we're all talking about the same themes of hormone action in cancers that are hormone driven. And so in my lab, what we recently found is one of the hormones we more recently started to study is cortisol, the adrenal hormone that is the life stress hormone. And it's known that life stress really contributes dramatically to cancer and very nasty breast cancer. And this is, it's been known, women in prison, women who work the night shift, women in violent situations, women in socioeconomic stress, all these stressful things, even women who work too many hours a week have a higher increase of breast cancer. So we started looking in the cells to see like what is happening with the stress hormone. And we very quickly realized it's cooperating with another hormone that very few people in the world really study. It's really studied in cardiology. It's called aldosterone, and its receptor is the mineralocorticoid receptor, which is very related, MR. Now we have ER and PR, estrogen, progesterone, AR, androgen receptor, MR, and GR. So we studied them all in my lab. And to me, that's really exciting because what it means, for example, in triple negative, we found this MR. There are already drugs FDA approved that work great, that millions of people are taking for minor kidney or heart issues. Can you imagine if triple negative breast cancer people could take those? Mm-hmm. There's 2 or 3 of them. Millions of people take them. They're not that toxic. Wow, right? Wow. So that's what I'm really excited about for my own lab. And then we're learning new things about the progesterone receptor that are super surprising. That the progesterone receptor was previously thought to kind of protect from the actions of estrogen, and they kind of fought together. And if you had a lot of progesterone, it would you had better outcome. And now we're finding that there's 2 types of the receptor, and now we're finding that there's a good guy, bad guy, there's a good cop and a bad cop, there's a Jekyll and a Hyde, and we're finding that through genetic data in our model systems that we get a gene signature. We can see in public data that that's a bad signature for one of the types, and the other types we get a good survival signature. And we just got that. I mean, we just got that. And we just got the ability before now, nobody clinically tests the 2 types of progesterone receptors in tumors. They just kind of group it all together. We have a way to test whether there's A and B, whether you have A or B and how much of each. B is the good guy, A is the bad guy. And then if we could learn that, then we could discover new drugs that amplify the good guy and suppress the bad guy. So that we're on the edge of that. That's really far out there, but because I'm a very basic biochemist. But to me, that's really exciting. The idea that these receptors cooperate really opens a lot more drugs for everyone with breast or prostate cancer. Prostate cancer people can take breast cancer drugs. Breast cancer people can take prostate cancer drugs, maybe in combination. So now you're starting to look at anti-androgens and anti-estrogens together. You know, like these are coming through clinical trials. And so it's super exciting, I think. And many, many labs are now onto this, not just mine.
That's really amazing. It just shows that research can really expand our knowledge and improve our treatments. That's beautiful. Any other questions? Are you excited about something?
Not as exciting as Dr. Lange. I'm sitting here like, wow. No, my excitement is continued collaboration, working with my colleagues in oncology, radiation oncology, surgery, to one, detect breast cancer when it's really, really small, so it, survival is increased, and then working with my colleagues to make sure that the patient is getting proper care. The drug side of things with the I-SPY trial, to be able to witness this ginormous cancer shrinking with the chemotherapy is amazing. And in terms of the tools that I've been using, I think still now we have trouble getting all women access to screening, and don't know why. We can think of many things, but it is. And so we continue that fight. And then what is the most effective tool for each person? Mammography has the longest data behind it. The first mammographic study was from 1965. And so you can imagine how much data we have, that it saves women's lives, decreasing mortality by 30 to 40%. But there are other tools such as ultrasound and MRI, and we're constantly researching, trying to figure out how to minimize radiation, but also at the same time detect breast cancer as much as possible. The most exciting tool is, it's not brand new. The first I heard about was in 2012, called contrast mammogram. So we detect breast cancer different ways, looking at the morphology, the shape, the edges, how it's interacting with the other tissue in the breast, but then also functional imaging. The belief is breast cancer is hungry, and it wants to eat a lot of food. So it's going to make brand new blood vessels to it as compared to the other tissue surrounding it. And so studies such as contrast-enhanced MRI, contrast-enhanced mammogram is designed to travel through those blood vessels, and the tissue that picks up that contrast earlier and faster than the surrounding tissue is one clue that this might be an area that we would be concerned about. So contrast mammography is coming up, and hopefully it'll have enough research data behind it so that we can utilize it more.
Beautiful.
I'd love to say just one thing. So I thought I recognized Dr. Church. So I was diagnosed with triple positive last January, and I did I-SPY, and I think Dr. Church might have done one of my 4 biopsies. I think you did.
I apologize.
I had long hair.
No.
I know.
Can you show me the pictures of your breast?
So yeah, I'll just tell you briefly, I had a breast cancer that was not visible by MRI at all. It would have been called normal. It was called normal. I had a screening MRI that I was lucky to have through a trial called the Wisdom trial, where they told me I was high risk and I should have an MRI every year. And so my first MRI, the technician was like, okay, we'll be back in touch with next steps. And I went, next steps. Woo! And so it turns out large tumor, lucky lymph node negative, triple positive. Dr. Yi, who was our cancer center director, he's recently stepped down from that position, but he's still practicing and he's still here and doing research. He was my boss. He hired me 27 years ago. He's a great clinical oncologist. He was one of the I-SPY authors. And so I went into I-SPY and I got a 90% reduction of my tumor volume during the I-SPY trial with new drugs that have never been tried and, you know, heavily vetted against standard of care. And then I got my surgery, my radiation, and now I'm back in standard of care. And I just had an infusion yesterday of my HER2 therapy. So thank you for what you do. That's why I have my short hair. My Judi Dench hair.
Yes.
Yeah. And it did come in a different color, which is really weird. The HER2, I'm on the HER2 antibodies. I had one of the drug antibody conjugates, which is the HER2 antibody linked to a toxin called M-santine. I had a allergic response to that. So after 4 cycles, we switched me over. Now I'm back on, the last 2 cycles, I'm back on Herceptin and Perjeta, which are the 2 sort of cooperating antibodies against the HER2 molecule. And, you know, so when I was training as a postdoc in 1998, the trastuzumab or Herceptin antibody was FDA approved. And it was only for very bad metastatic breast cancer. You had to have multiple, you know, recurrence. And I remember as a postdoc sitting around with my advisor saying, they have to give this up front. Why don't they do that? You know, and 10 or 15 years later, they learned that if you select patients with biomarkers for the amplified HER2, so when they didn't select patients, they just did the whole pool, no real benefit, maybe a 5% benefit. But when they selected patients who they knew had a lot of HER2, 50% reduction in recurrence and death. So then that became a big deal, right? So that was kind of the really big new targeted therapy. And now all of the drug antibody conjugates, which are that same antibody hooked onto a this or that or the other, delivers it to the cancer cell eats that, and then hopefully, right? So right now on the Herceptin Perjeta, I'm doing much better. I mean, I just was there. Yeah, I get a little sweaty after like a day or 2, right? Like rolling cold flashes, right? So I had it yesterday, and I'm fine. It was good. But thank you for asking.
Beautiful. Another question.
Can we ask questions of you as well?
Yes, of course.
First of all, oh, sorry.
Thank you.
Thank you both. It was just so neat to hear from you guys and everything you do. I'm also in the I-SPY trail. Just about to start Block C. My question is on the so when I started the I-SPY trial, like everything was like moving fast, and you're like, you just got to go. It's like it's a marathon, but it's a sprint kind of, you know. And then I'm like, I'm not in healthcare, I'm in education, and so all this was new to me. And sometimes I finally like was able to kind of take a breath and look at the like, I start to like Google the longevity, mortality, morbidity, those types of things in January before I started Taxol. And I was like, okay, this is a great idea. I'm gonna like look at this, and then I'm gonna ask my oncologist, Dr. Potter, who's amazing, like what his thoughts are on this, because I'm finally ready to talk about it. I'm stage 2B with ER positive, HER2 negative. And he said, we don't believe in giving those statistics anymore, like mental health. And also I think they have like from a science perspective studied that that's a bad idea, that you like live into the negative kind of. And I remember one of the stats I'd found was like, and I didn't look very hard because it actually did freak me out. And I'm like, I should probably like not be doing this on my own. But like one was like 69% of women with a luminal B tumor make it 20 years. And I was like, I always used to be the person to be like, I'm going to live a very old age, you know, like, I don't know, maybe that's like the naivete of youth or whatever. I'm 41 now with 2 kids. And I was like, I went in and I was freaked out, and he was like, no, we don't actually believe in that. He explained that. And at first it was like, I was almost angry. Like, what do what, you're, I can't go on Google by myself. And now you're saying you know information. And then I was like, took me like an hour, couple to process. And then I was like, oh, okay. He obviously knows I have full trust in you. Okay, so how do I get on board with this? And I realized I was able to shift my thinking into, okay, I am going to believe I am going to live into old age again. I'm going to go back into that and believe that. But I have a hard time, and I don't have a therapist or anything right now. I'm going to start with an oncology therapist at the U in a week. But how it's like hard to, it's like those things seem opposite. Like I'm going to believe that I am going to live into old age. I mean, a goal of mine is to be a grandma, but then how do a lot of my life, I have been a very hard worker, probably cortisol all the time, charging ahead, achieving everything I could possibly think of. And then wait a second, now what if and I want to change it. I have changed, but they seem like opposite to me. And I struggle with that. And maybe it's really obvious. Everyone else knows the answer, but yeah. So the question, does that,
Yes,
I'm not
that makes-
articulating my question really, you get the question.
Yes.
Okay.
Yes. I've treated a lot of patients that have the same concerns as you. I always say, do not Google. Please do not Google. That is my number one advice. People will say like, oh my gosh, my mother died of stage 1 cancer. And then you'll be like, oh my gosh, am I gonna die? And it just increases the anxiety. Another thing I see, especially with people who are perfectionists, maybe, or go-getters, they may see in this like black or white thinking, right? It's going to be either this or this. And I like to live in the gray, right? And be realistic, right? Maybe I will live till I'm 70. Maybe I won't. Maybe I'll live till I'm 100, right? Maybe I won't. And at the same time, does that mean that I can't live a wonderful and beautiful life? Right. And that anxiety may prevent us from being present and being with our families, with our children, all those things. So living in that gray and also, coming to terms with your emotions, et cetera, and being present can be quite helpful in that situation. Does that make sense? Is that helpful? And I'm sure your oncologist therapist or psychologist is probably going to say the same thing. But yeah, I completely understand what you're saying. Does that, yeah.
And it's not obvious. I mean, I had the same things, and I'm research focused, evidence based, and of course I looked up all the actual publications. I didn't Google. I went to PubMed, which was also a mistake. Don't go to PubMed. Yeah, right. So, but one thing I tell people too is I have another friend who's going through what I just went through, and I say to her, right now, today, the therapies are so agile. Your oncologist is going to work with you, and they switch you all the time. Like I've switched so many times in 1 year to different things because things weren't working, or they were too toxic, or they were, and even like Doug's physician assist, Doug's PA, Dr. Reinhardt, she's amazing. She's like, Carol, it's early days. We got so many things we can try. So in those clinical trials, they're using data from kind of very similar patients who went through the same stuff. So like there's gonna be this ability to have very personalized care, which will really improve outcomes. And there aren't studies like that. I mean, I-SPY would be the closest to that, I would think.
I think what you're talking about speaks to what we've been talking about, the mind-body connection, stress. We're seeing how much important it all is. From my side, I see people who have no symptoms. They have no idea. And I get to tell them that they have cancer. And the data is that the 2 biggest risks for breast cancer is 1, female sex at birth, 2, age, neither of which we can change. So then how do you live in that aspect? I tell my patients, and I believe for myself, that it's not if I get breast cancer now, it's when. And And so, but that's my belief. There's, I don't think you might not be able to Google that, but that just makes us be more prepared of what can be next. I'm 5th generation firstborn female. So talking about type A to the 5th power. So it's, and that's what I do. I look for minute little changes from year to year on a person's mammogram or imaging. And so our hope is to, when that shows up, to catch it as early as possible. And it's amazing how it's okay for us to be able to live with the probability that we could be hit by a car tomorrow.
Yes.
Yeah.
I never thought about that. Like, I was like, well, it's just the cancer patients that have the mortality costs. It's like, no, other people, anyone.
And this is
Good.
and that's why this conference is so beautiful and wonderful. When I talk to a patient that I fear that it might be breast cancer, I inform them that there's a community of women that they're going to be entering into, and they need to seek that out. Ask their oncologist, ask their surgeon, where is that community that I can meet, and because they know exactly what I'm going through.
And also, like, cancer is a huge blow to your identity, your expectations for life. And a lot of the work that I do as someone who specializes in cancer psychology is managing those expectations, and maybe they look a little differently, right? Maybe I'm not going to be able to climb Mount Everest, but maybe I can take a walk with my dog in the park, right? Or maybe I can take a local trip, right? So managing those expectations. And as far as identity, right? What do I value now that I've gone through this experience? Maybe that's a little different than what you did pre-cancer diagnosis. And that might be okay. Maybe you don't want to be a workaholic anymore, right? That was a really huge part of your identity, but maybe that has to change now, right? And being okay with that, I think, is huge.
Yeah, we have maybe just time for one more question, maybe two. Now we've got hands up, but I know we do have an agenda, although this is lovely.
Mine is just a quick follow-up to that because I'm a very analytical person. I'm a lawyer by training, and so statistics and all of that, that's really my jam. I like to get in, but at a very early age, I had Lyme disease, and that really affected my life. And then I had MS. And so I learned a long time ago that living in the moment is the way that you deal with that. If you spend a lot of time thinking about the what ifs. So I don't want to know a prognosis in years because I want to focus on quality of life today. And nobody promised me any tomorrow, and so I'm going to make the most of what I have, and I'm perfectly good with that. The problem that I have is that other people then ask me, and when they say, what is your prognosis? And my answer is, I'm living in my moment and I'm living my best life for as long as possible. And when they come back, then, well, what did your doctor say? Well, I have Dr. Ann Blaze is my doctor, and she's wonderful. I love her. She understands that I'm a very analytical person. And so she gives me far more information than probably most people, because if I understand something, I am much more prepared to cope with it, even if it is bad information. And then they start, well, why wouldn't they tell you that? And I just like, what is a one sentence good way to shut people down on going down that rabbit hole? Because I don't want to go down that rabbit hole, and I don't want to defend my doctor. I just want them to shut up and go away.
Yeah.
My doctor is not God.
Yes, I always tell patients that you can set boundaries. You can tell people, I do not want to talk about that, and I don't appreciate you asking me that question. I would like to talk about something else. Period. That's all you have to say. And whatever language you like to use. Mine might have been too blunt, but whatever voice you like to use. That's what I always tell people. You get to craft whatever your journey is. You don't have to talk about things that you don't want to talk about.
We have our last question here.
Hello. I was also on the I Spy trial. You also did some of my biopsies. Also triple positive, still taking HP. I made it through block B. I also have Blaze and I adore her. So I work for a tech company, so I guess this has come to mind. All the research is super exciting, but I'm also curious if there are other emerging technologies. I think about like AI or anything else that excites you in terms of being able to detect. Do you see other technologies like AI coming into your work to be able to detect cancer early, treat early? Yeah, I'm just curious.
That's a challenging question because I think the perception is AI is supposed to be this miraculous thing that will solve things. And, but we're still trying to understand it. We don't know how it works even. And so if we don't know how it works, how we're going to use it well. And so there's so many organizations, so many startup companies that are trying to use AI in trying to read imaging better, mammography better, ultrasound better, etc. And if they were making such good strides, we would be using it now. So what we can do is keep working with these innovators and bring in our clinical expertise and how together to detect breast cancer earlier and more safely.
And I'll just add that, so AI in the research space, some examples that might be useful for people is, so you have to realize that AI is sort of crowdsourcing. So garbage in, garbage out. Okay, so if you see misinformation or disinformation 10,000 times, the AI is going to see that. It's going to spurt that back out. It's not going to know what's true and what's not true. And it's going to give you things that are not true. But I've, for something like a very high resolution molecular structure, you have a molecule, it's very expensive to do very, molecular structures at the most minute level. X-ray crystallography or scanning EM, these kind of technologies, you can query, like every structure that's ever been published, put your molecule in, and the AI will come up with a most likely structure. And then based on that, I would say that's going to give you a hypothesis and kind of a starting point in which to query that structure in the laboratory. So that's like one example of how computational biologists and people who do a lot with binding interactions that are on the very minute level in the cell are using AI that way. And the other weird thing that's happening, I'm an editor. I was editor-in-chief of Hormones and Cancer and editor-in-chief of a journal called Endocrinology. And what I noticed with AI is now you're getting like paper mills that are cranking out papers, mostly like often review articles, but actual papers, making them up. And then as an editor, you're reading along and it sounds good. It sounds great. You're like, okay. And then like deep down, there'll be a sentence like a red herring that just doesn't make any sense at all. And it's just like, what? And that's not true. And that's a big red flag. Okay, that was generated by an AI. And then you reject that paper. And now there are trainings for reviewers of, like editors and for the community of peers that's reviewing that work. You can kind of spot an AI generated piece of work. Now, so they can be tools to help you. So my postdoc fed in her entire grant to the AI that she wrote, 12 pages thick. And she asked the AI to come up with one summary paragraph for the whole grant for, 250 words. It spits it out in 15 seconds. And then she just edits it and make sure it's right. And so that saved her several hours. So that is a great tool, but so there's good uses and bad uses, right? And we still don't know where it's going. So I have not used it yet. I'm afraid, I don't even know how. I'm afraid of it, but I'm kind of old school, so.
Well, I just really want to thank you, Dr. Lange, Dr. Muse, and Dr. Church for joining us. What a great way to start the day. Unfortunately, we've got a load more amazing speakers, fortunately and unfortunately. So with that, again, thank you all so much for kicking us off today. Thank you, audience, for your questions.